Very good. Well, welcome to day 3. Ooh, man, you guys are tough. Come back for a third day of 5 hours of CE. Man, what is wrong with y'all? Accreditation, right? You got to have it, right? So I'm going to make this as entertaining yet educational as possible. I've been on the road since Tuesday. I'm on the ID Week Planning Committee. It's a 12,000 person meeting that's going to be in Los Angeles in October. So we planned it a year in advance. So it's a big undertaking. So I'm very thankful to be here, and I didn't miss a plane and didn't have any travel issues. So I could be here with you today. So good to see the mix of people who professions that are represented here. Pretty exciting time for me and my family. So I'm married. My wife's a pharmacist. I have 3 kids. My 2 daughters are in college, and one of them just finished her first semester of nursing school. So I've dealt with a lot of pain and suffering this semester, let me just tell you. And as a faculty member, I have a unique perspective on pain and suffering, right? Because I inflict it a lot on my students, not willingly, or try to talk with my daughter. So first semester down, she's got like 2 finals left, and then she'll be home Monday. So mom and dad are very, very happy. So we're going to have a good session here today. I've got 4 different topics I'm going to go through. Obesity management, which I know nobody's really talking about that. I'm kidding. All right. It's like everything you pick up, right, is about obesity management. We're going to do an ID review, and that's my area of research at the University of Georgia. We're going to do drug interactions, kind of fun case-based ones that I'll take you through. And then we'll do a polypharmacy one as well, because that's a topic that year after year, that's one that's hotly requested by our attendees. So I've been speaking for University Learning Systems for a long, long time. This is probably close to my 15th talk ever that I've ever done. So they do a great job. So we're gonna have a good time. And I'm very laid back. Hopefully you've gotten that in the first 5 minutes. Conversational. If you have something you want to say or contribute, just go ahead and raise your hand and do that. This is not a formalized, I speak for an hour and then questions. This is your conference. I'm just here to provide information. This is for you. And if you have any comments or questions, feel free to go. So I do work for the University of Georgia. Everybody's been consoling me lately, I guess, because of the football team. I actually don't root for the football team. I went to the University of South Carolina for pharmacy school. And I worked for the federal government for 15 years. I worked as a clinical specialist. I did infectious disease, critical care. About half my time towards the end was in family medicine, which is where I did a lot of what I'm talking about here. We got a future med student here and wants to do family medicine. And so with that, that was where I got a lot of my interest in these topics, especially obesity, because I started a kind of its first of its own medication management clinic for people who have had bariatric surgery. So now I've seen it come full circle where you're going to have a lot of different options for obesity management, including meds, but then also surgery. So I worked for the military as a civilian for almost 15 years. I said, you know what? I've built up all my vacation time, all my benefits. Why don't I leave? That would be awesome. I was kidding, right? People thought I was crazy, right? But I've always wanted to teach. I've always loved mentoring. I've always loved researching. And so in 2015, I packed up my bags from Augusta, Georgia, because I was in Dwight David Eisenhower Army Medical Center, and headed to Savannah, Georgia. Anybody been to Savannah? Yeah? Oh man, you're missing out. It's a beautiful city. Please come. It's a great weekend city. That's what I would say. A lot of people on their way to Florida will stop in Savannah for a weekend. You won't regret it. And so I started there in 2015 to start that campus. It's an extended campus from Athens. So I'm also the co-founder. I'm actually just celebrating my year anniversary of Teach Me Pharm. I feel like people are very intimidated about learning pharmacology and drug therapy. So I started this with 2 other guys in Ohio, Matt Coughlin and Mike Koreski. We make videos essentially on how to understand drug therapy. So it's me talking or it's Matt. We do drug therapy videos on disease state. We do it by drug class. Or now we've started something where we do the top 200 drugs. So I'll have a drug like Augmentin, And I'll have 10 minutes where I'll tell you everything you need to know. That's our tagline, what you need to know about drug therapy. So I appreciate Charlene letting me say that. But I started that a year ago, and it's been fun. It's one of the hardest things I've ever done, but it's been a lot of fun. So let's go ahead and get started here. Obesity meds. When you hear obesity meds, right? A lot's been going on in the news with this topic. And what's some of the things you're hearing? What are your patients asking you? Lack of availability, scarcity, right? Lack of coverage, right? Is insurance going to cover these meds? That's the big question, right? Because interestingly, I'll save it. I'm kind of like radio. I'm like going to save it for later in the talk. But Zepbound, right? They just came out and said kind of what they're going to charge for people that don't have insurance. Okay. But yeah, coverage, insurance, scarcity. For Mounjaro, before Zepbound was approved, they had on TikTok a Mounjaro journey. That's what they called it. So people were on TikTok, and that's what they would do. They would say, hey, CVS on Fifth Street has the 10 milligram dose. And then people would just like flock to that. It's crazy in the era of social media and information, how fast information can go. So scarcity, coverage, a lot of questions we'll get into. So I'm going to cover a lot of the different med classes, not just the GLP-1s, although that's where a lot of the questions are, because this is a CE. We have to be balanced to discuss each of these. Now, some of these we're going to have fun and laughing at because I haven't used them in years, and y'all all know why. You'll see why. All right. So we're going to do patient populations, key characteristics, including the GLP-1 agonists. So obesity in America. I was just in Guatemala on a mission trip for about 5 days, and a totally different situation, right? There was scarcity of food, resources, you name it. Much different situation here in the U.S. So prevalence in the U.S., as you know, is tremendous, right? Tremendously. I lost 70 pounds 20 years ago. It was the hardest thing I've ever done in my life. And I failed like 10 times before I did that. Okay. And so this is something that we've got to get a hold of. Obesity is much more complicated than calories in, calories out, exercise or not. It's much more complicated that with genetics and a lot of different factors that we're now discovering. Look at young adults though. I mean, over a 40-year period, it's 500% higher than it was. Thank you, iPhone. Thank you, cool computer games, PlayStation, you name it, right? My son, I have a 13-year-old son. He loves being outside. That's hard, though. It's a challenge. He even asked me the other day, Dad, are you sure I can't get a PlayStation? You know, so that's a thing that we're constantly, of course, dealing with. And so this is expected. And I read this in a journal or online probably about 2 months ago. And it said, this is expected to be $100 billion industry. So this is going to be a battle on your TV set, right? For advertising, battle for getting in front of you. I know the last time I did this talk a while ago, there was somebody from one of the companies in here kind of watching to see what I was going to say, right? And so with that, this is expected to be $100 billion industry. It's going to be huge. And so there's still, like, we are just now kind of crossing this. This is the dial-up internet phase of the internet, right? We got a lot more to go with cable modem. What do you think, Andy? You like my dial-up reference? Only you and I got that, so it's all right. But you get it? All right, there we go. We got a few dial-ups in here. All right. I would never, if you want to admit it, that's fine. But I'll admit it freely. That was my first, I remember my first computer with dial-up internet. So we're very young in this era. It's exciting to me, y'all, because I think we're going to finally manage obesity the way it should have been managed a long time ago. The complexity of it. So when you look at how obese are Americans, 12 million have a BMI greater than 40, okay? It's expected that there'll be over 500 million diabetes patients worldwide by 2030. So when you think about that, and I saw this in Guatemala too, is that what are the things that are freely available, right? poor food that you should not eat a lot. They did have some produce stands, but overall there was a lot of eating. Their favorite food, we have it here, Takis, right? They love Takis. They all were eating Takis. And I'm like, oh, that's not good long term, but not a lot of benefit from a nutritional standpoint. But less than 50% of diabetes patients meet glycemic goals. So you think about how many people are in the US, right? 350 million or so. So imagine if every person you ran into in this country had diabetes, then we still had 150 more million to go. So this is a tremendous, tremendous problem. And obesity and diabetes are very clearly related. And all of these different complications here from all the way from diabetes. But look at this one, right? Cancer. So that's my biggest fear, is that one of these weight loss drugs causes cancer the longer you're on it. That's actually my biggest concern. And I'll kind of skip to that in a minute, but I don't have any concern because of that. But I know we do know GLP-1s have this quote unquote association, more animals with thyroid cancer. Okay. But just showing you that this excess weight, the inflammatory cascade that results from that excess weight really can induce mutations and ultimately some forms of cancer. Asthma. Anybody got asthma in here? I had asthma as a kid. Man, worst day of my life. I was at Six Flags and had an asthma attack. Had to go to the hospital. You know what I had? I didn't have albuterol. I had Primatene Mist. Y'all ever seen that? Why is that still in the market? All right. It's basically epinephrine in a bottle. But yeah, so it affects all these comorbid conditions. Not surprising to this audience. This is my favorite slide. I'm going to show you all day. Picture's worth 1,000 words, right? All these things that are affected. Now, this says bariatric surgery, but this is obesity in general, right? Metabolic syndrome, gout. Look at this. But the bottom line is quality of life and mortality. Mortality has been definitely shown with bariatric surgery, a mortality reduction. Question is, what about the weight loss drugs? That's the ultimate question, because insurance companies surely are not going to cover these unless if they just cause weight loss. That's an intermediary goal to what we really want, and that's decreased strokes, heart attacks, death. So that's the question. I've got some news for you today because there's some new data that's out, okay? So BMI, I know BMI, it's not the greatest thing, right? Everybody loud, you know, it correlates some, but these are the BMI categories so that when we're going through some of the studies, you can kind of know where we're at. So a BMI of 25 to 30 is overweight, and then about every 5 numbers higher, you get to a different obesity class, all the way up to a BMI of 40 or greater, and that's going to be obesity class 3. So the reason why BMI is kind of this useful, not perfect number is it correlates between the 3 of these probably the best. It takes into account waist circumference, fat mass, abdominal visceral fat. In the middle, it has the highest correlation to waist circumference and fat mass. And so that is why this has been used historically for bariatric surgery, categorization of who's eligible, but then also just in general degree of obesity. Now, I love pictures, so I'm going to show you. This is straight from the CDC website. Your taxpayer dollars have paid for it, and mine, okay? So let's look at the age-adjusted prevalence of obesity and diagnosed diabetes by adults. And this is adults only, not children. So this is 2004. What were you doing in 2004? You weren't alive, were you? No, I'm just kidding. How old were you? 4 years old. Oh, man. Oh, those were the days. 2004. I was actually on a plane last night. I think it's the oldest plane still in Delta's fleet. They had those little small screens and the DOS, and it just didn't work. And it said last updated 2004, Andy. I'm glad you weren't there. You would have collapsed. But anyway, so this is 2004. The darker the color, the worse. Right? Because the darker the color means you got a high amount of diabetes and a high amount of obesity. Now watch what happens. So, you know, a lot of light green here, not too bad, kind of in the middle, lower. Let's see what happens a few years later. Wow, not good. 2016. That was right when I got to UGA, right? And then, oh, wait a minute, there's more. Now we got a new map. So this is directly on just obesity. And you can see that by state, now we've only got a few states left that don't fit into this orange dark 30% or more category. Nevada's not one of them, okay? California is one. Colorado, a lot of outdoor hiking, good weather. I was at a conference like this a couple of years ago, and a guy from, anybody from Wisconsin? He called it SOD. And I was like, what is SOD? And he's like, seasonal obesity disorder. From like November to March, people didn't come outside because of all the snow and ice. So they would put on weight. A lot of cheese, a lot of beer, a lot of not exercising. But you can see this is just tremendous now. You've only got about 5 or 6 states where they're going to be even. But even those states, 25% of the population is obese. 1 out of every 4. Yeah, what's that? Yeah, DC. Yeah, oh, there is a green. Look at you, Andy. I was just in DC. Yeah, a lot of public transit, a lot of walking. Yeah, thanks. Yeah, exactly. So a lot of work to do. So this is why this is going to be a $100 billion business. There's a lot of opportunity. Now, when should we consider drug therapy with obesity? Now, the first thing I would say is initial weight loss efforts have failed. And these are like true weight loss efforts. Now, look, I tried to lose weight 10 times before I finally got it. But, I'd try for a week or 2 and quit. That's not really what we're talking about. We're talking a good, 3-month trial to do this. Because what you see in these studies, and I won't go through it, is that the placebo arm, they a lot of times lost a decent amount of weight, even just by getting on an appropriate exercise regimen, calorie restriction, you name it. The goal is a 5 to 10% weight loss goal because that's going to decrease your risk of diabetes, hypertension, hyperlipidemia. Exercise, behavior modification. What are the BMI categories? You're going to see this throughout my presentation. BMI of 30 or more, pretty much anybody's eligible for a weight loss drug attempt. There is one drug that's a little bit lower than that, or a BMI of 27 or more, plus a comorbid condition. And so this is going to be one of the conditions we talked about that obesity can cause. Okay, so these are typically when we start thinking about drug therapy. Now, I've got some pearls on it because I know it's early, you're awake, the coffee's kicking in. If you're an East Coaster, it's almost lunchtime, right? So here's what I need you to know. What are the pearls of these drugs, whatever we talk about? The first one is, and this is the big advocates for bariatric surgery, this is what they always point to. Weight loss goes away when you stop the drug. So this is very much like a statin, where if you stop your statin, your benefit goes away. It's the same thing, okay? So the weight loss benefit stops upon discontinuation. Therapy should be stopped if 5% or more of weight loss does not occur. Why? Because in reality, there's lots of other drugs that will accomplish that. I mean, the GLP-1s and now the newest agents we have over the last 2 years easily accomplish that. We don't want to waste time with drugs that are not going to accomplish that. 5% is the bare minimum. Not indicated for use in pregnancy. This is not a time to be worried about losing weight. And there's a lot of safety data that's not been demonstrated in that population. There's significant side effects with the older agents. We're going to talk about those. I'm going to blow through those pretty quickly because they're a lot of side effects associated with them. They are cheaper than some of the newer agents, but they do have their problems. And then most effective drugs require a very slow titration, months and months, right? So this is not something where you go to the highest dose of Mounjaro in week 2. It's going to take you probably 3 months to get there. So As long as patients understand that, you're going to be okay. Most study participants are predominantly female. They care, I guess, weight loss goals are higher on the list than males. So most of these studies, most of this data is going to apply to females. There are some males in the studies, but those are the pearls. So these are the classes of drugs we're going to talk about. And I put a big caveat here for now. I got a feeling in the next year or two, there's a lot of these that are currently in phase 2, phase 3 studies, may or may not get approved. I don't know. I don't like to get too high on a drug until, literally or figuratively, until I know, some of y'all caught that, all right, until I see it FDA approved, because I've been burned by that in the past. So these are some of our agents here. So you got sympathomimetics, you've got those with anti-epileptic drugs, lipase inhibitors, your opioid antagonists, your antidepressants. You've also got your GLP-1s and GLP-1 GIPs. We're going to spend some definite time there because that's where most of the discussion is occurring. Okay, how many of you know, haven't you seen this in a while? Orlistat, Xenical, baby? Oh, yeah. You must really want to lose weight if you're going to use this one, okay? So Orlistat was like the first kind of weight loss drug. I remember when it came, not the first, but one of the first OTC. So OTC, it's called Alli, A-L-L-I here. So this one essentially is a local fat absorption inhibitor. The whole idea is you give the drug, it takes out the fat from whatever meal you've had, and decreases that fat absorption, which then decreases weight loss. It is one of the few agents that's approved even really once you get overweight. Can't use it because you're not going to lose a ton of weight with that drug. Minimal weight loss, about 3 kilograms on average, not great. A lot of it depends on how much fat you're eating, which then can lead to toxicity, all right? And this is the big one: flatulence, oily stools, fecal urgency, okay? Plenty of case studies of people taking this with like Papa John's, high fat meal, and just feeling awful afterwards. So the tolerability of these agents is very, very low. The other thing about this drug is it can definitely, because it takes out the fat from your meals, it also can decrease your fat soluble vitamin absorption, your A, D, E, and K. That's not going to be good long term. And so a couple of other drug interactions. It can interfere with levothyroxine. So you want to take this 4 hours before or after Orlistat. Warfarin, it's kind of hard to control warfarin on this drug because it vacillates with the amount of vitamin K that it's taking out of the diet. So that's very difficult to sustain. And cyclosporin, it may decrease those concentrations, which of course that is a major problem because that's an immunosuppressant used for people after liver and kidney transplants usually. So don't ever use it with that. So bottom line with this drug, it's more historical in nature now. We do have it, but I do always talk about it because I know there are a lot of, you're going to get these questions. And patients, this is available over the counter. This is one we do have that's over the counter that anybody can go get. And so when they ask questions about it, this is one I typically steer away from, but you need to be knowledgeable about it because your patients may be taking it. All right, sympathomimetic amines, right? These are controlled substances. Phentermine, diethylpropion, a lot of abuse here. We had 2 surgery residents kicked out of our program about a decade ago because they were prescribing it for one another to stay awake. Surgery residents, right? They're working like 70, 80 hours a week. And so unfortunately got kicked out of the program. These can have addictive potential, very stimulating. Again, though, you stop them, the weight comes back. The whole idea is it stimulates your brain to where you're not hungry. These are only FDA approved for 12 weeks. No one takes them for 12 weeks, right? They take them for as long as they want to, and then they stop them. So, but they're often used much longer. Limited weight loss. Biggest toxicity concerns, of course, cardiovascular and CNS. right? It's like hit with speed. These things make a lot of insomnia, anxiety, tachycardia. Think about you before an exam, you get all anxious and tachycardic, sweaty, right? So a lot of non-adherence. People take them. They're like, man, I do not like how that made me feel. They may be drinking Starbucks along with it. And then before you know it, they got supraventricular tachycardia and they're like, I'm not doing that again. So, but a lot of people still use these, phentermine for sure, Adipex. There used to be the fen-phen combo, phentermine and dexfenfluramine. That really got removed off the market due to heart valve abnormalities. So you shouldn't see that. So the guidelines are like, nah, it's more of a low priority agent, and don't even include it as a primary agent because of that side effect profile. Qsema, have y'all seen this? Bet y'all have seen this one. So this is phentermine with topiramate. So kind of taking some of that away. This has been studied a lot better. It's got longer term data compared to just phentermine alone. The weight loss is definitely dose dependent. Now, topiramate, right? What is topiramate used for normally? Do y'all know? Seizures, exactly. Seizure drug, migraine prophylaxis at times. So it has really good CNS penetration. So because of that, you got to titrate it slowly because you can get some pretty good CNS toxicity, side effects. Dopamax, Topamax, people call it, right? Word finding difficulties. They can't really figure out what they're trying to say. But the dosing here, usually for 2 weeks, and then for 3 months, you use this middle dose, and then thereafter you use a little bit of a higher dose. So it's definitely a dose dependent issue. Have seen some significant benefits with this one. Let's show some of the data. So 3 primary trials that have shown data here. I won't beat you up with trials all day, I promise. I'll try not to do that, okay? Allison, we looked at BMIs of 35 or more. That's a pretty tough population because that's the population we usually think about for bariatric surgery. Okay, so that's the highest difficulty population. Gaddy used a lot of different BMI categories, 27 all the way up to 45, but they had comorbid conditions. And then the Garvey study looked at 27 to 45 as well, but specifically with diabetes. And they looked at these patients for a year. All patients, and you're going to see this throughout my slides, all have to do calorie restriction. So if you have patients, they're asking about these weight loss medications, you got to tell them that, hey, just so you know, in these studies, everybody restricted their calorie by 500 from what they were doing previously. That's a low bar for them. That represents the study. It's kind of like the smoking cessation studies. Everybody thinks they can just take smoking cessation pills and stop smoking. It's not true in the sense that they all were undergoing intensive counseling every week at the same time. And so it's not just a pill. Same thing here. We're trying to do what? We're trying to replicate what happened in the study to get the same results. Now, here's the best thing I'm going to tell you all day, because you'll be like, whoa, that makes sense. Okay. There's going to be a lot of numbers I'm going to show you, but here's what you need to keep in mind. The average person in these trials weighs about 100 kilos. So when I start talking about percent weight loss, remember, they're 100 kilos. So if they lose 15% of their weight, they lost 15 kilos. And that way you can keep it in your mind how much they're actually losing. Fortunately, it's a nice round number, 100, okay? Waist circumference, 109 to 120 centimeters, BMIs, somewhere between 35 and 40. So these were high-risk patients. So what they showed, the best data was for this 1572, so that one of the higher doses, because if you look back here, that's the highest dose that you want to target, okay? And that's pretty common. So with that, almost two-thirds of patients lost 5% of their body weight. So that's why we say if you don't lose 5%, you need to try something else, okay? Similar results for 10%. So most people who lost 5% lost 10%. So it's very effective. It's also FDA approved, just so you all know. for 12 years and older. And so I can answer that question. I have a 13-year-old. And so this would have to be a significant conversation between myself, my son, and the prescriber to really think about doing this. I think this is going to get some traction, but again, 13-year-olds still growing, a lot of unanswered questions, but it does have some data in this population for the standardized BMI 95th percentile or greater. So these are the highest risk adolescents who have gained weight. So the guidelines put this as a conditional recommendation with moderate certainty. So kind of in the middle as far as their recommended drugs. Now, as far as safety profile, most of the patients, and this is interesting, right? Because you think about phentermine, that's a vasoconstrictor. It can cause hypertension. But if you're losing 10 kilograms, what's going to happen to your blood pressure? It's going to go down. So actually, about half the patients that had hypertension, most of them, in fact, all of them had a mean blood pressure drop. So even though the drug itself, by itself, can cause hypertension, pharmacodynamically, when you lose the weight over time, that actually affects your blood pressure greater, and you actually lose blood pressure and you get a blood pressure benefit. So that's pretty cool. In fact, more people in the treatment group had to stop the med because their blood pressure was getting too low. Interesting, right? Another thing too, this is kind of an interesting thing that's buried in the literature. If somebody has to undergo anesthesia for whatever procedure, you're supposed to stop this drug 4 days prior, because essentially what it's doing is it's depleting all your catecholamines. And if you're undergoing surgery, you need catecholamines to maintain your blood pressure. So if somebody has to have surgery and they're on this drug, they really should come off. Now, that's tricky. So pyramate, my rule of thumb is any CNS drug, you never stop abruptly, right? So in reality, if I knew somebody was having surgery, this 4 days thing, I might titrate it off starting even further before that, probably a week or two, to try to get them down, because they're going to have some refractory side effects, probably just from the withdrawal of the drug. Keep in mind, topiramate is contraindicated in pregnancy, a lot of different side effects. I think you are very familiar with this. It's a carbonic anhydrase inhibitor. It's how it works. So kidney stones. Kidney stones are a known issue with this, as well as just cognition, memory, word finding difficulties. That's why it gets called Dopamax. Now, our next agent, Contrave. Y'all seen Contrave? Yeah? So this is naltrexone, which is an opioid antagonist, and bupropion, old school Wellbutrin, which is a dopamine-producing antidepressant. So we know the dopamine is linked to a number of different benefits, such as smoking cessation. And then another one here is weight loss. So from a dosage standpoint, I pulled this directly from the package insert. By the way, perfectly legal. Anything the FDA or the CDC or any federal government agency prints, you can copy and paste it all day long. It's in the open domain because our money pays for it. So it's ours. You can use it for whatever you need to. So if you see here, it's very slow titration. This is what we talked about with our key principles. Morning dose, 1 tablet. Nothing in the evening. Week 2, 1 and 1. Week 3, 2 and 1. Week 4, 2 and 2. So about a month it takes you to actually get to full, what we call full dose. Efficacy-wise, look at that. Look at that baseline weight, 100 kilos. I told you, it's about 100 kilos no matter what study you pull, which is great because that makes the comparison of the different weight loss very, very easy to do. Some studies had diabetes, some didn't, but they all required this 500 kcal drop in your calorie intake and encouraged exercise. So the newest guidelines that have been published, this Grunwald, it's been out now like a year. I'm surprised it hasn't been talked about much more. I feel bad for them. Their timing couldn't have been worse because it happened right before all the GLP-1s, like some of the newer ones came out. But it's a really good, thorough guideline that you can pull. So most patients that got this drug, of course, lost 5, 10, or 15% or more of their total body weight. So you say, well, how do you interpret these statistics? Well, there's two things you want to do. So number one, see these confidence intervals? Okay. If they include the number 1, it's not a statistically significant finding. So you see here 1.41 to 3.37, it does not include 1, right? It's 1.4. So you can say, and what is this RR, relative risk, okay? So what this means is it's a 2, right? So how do I interpret the statistics? Here's how you interpret it. Number 1, this is a statistically significant finding. Yes. Number 2, this drug compared to placebo, you were twice as likely to lose 5% of your total body weight compared to placebo. Does that make sense? Go to the next one. What about 10% of your body weight? Is this statistically significant or not? Yes, does not include 1. And it's a 3.04. So that tells you you were 3 times as likely as placebo to lose 10% of your total body weight. And then the last one, 15%, you're nearly 4 times as likely. So if here's what this tells me. If you have a good benefit from this, it's going to be really good. That's why you see contrary views. Some patients that don't have a lot of benefit, but the ones that do tend to lose a lot of weight. Okay. Side effects, though, a lot of discontinuations. Naltrexone, not a drug you're going to be using in people on chronic opioids, right? Bupropion is a very stimulating drug. Some people just cannot tolerate it. Nausea, a lot of the GI and CNS side effects, right? It's an antidepressant, right? We know it works in the CNS, right? And so you see these. So again, it's kind of a busy slide, inappropriate for those on opioids. Don't forget about those going for surgery, because again, they're going to go to surgery and they may get opioids, right? So even though you don't have to stop it like we did the previous drug, this one, they're on it. Man, you try to give them an opioid, it's not going to work a whole lot. So usually we stop these prior to surgery. These have the highest rate of discontinuation. So risk reward, right? High amount of good things, high amount of discontinuation. And this study did not include GLP-1 agonists, which of course, now from here on out, that's probably going to be the standard as far as what we do. All right, now we're going to get into GLP-1s. All right, so we've done kind of the old school drug. I would argue this is old too, but it's a GLP-1. Liraglutide Saxenda was one of the first it was the first GLP-1 weight loss drug. It's approved for, again, that standard BMI of 30 or more, or 27 or more with a weight-related comorbid condition, i.e. hypertension, diabetes, sleep apnea, okay? This one's also approved for 12 years and older and adolescents that have an initial BMI 30 or more corresponding to adults, or a body weight of 60 kilos or greater. Now, as we get into the GLP-1s, you need to think G, GLP-1, G, GI side effects, okay? So the major issue with all of these GLP-1 drugs is tolerability of nausea, vomiting, diarrhea, okay? So for all of these, there's going to be a slow titration. Now, why are you probably not going to see Saxenda? How many of you have prescribed or dispensed Saxenda in the last month? I got 0 hands. If you got them on Zoom, by the way, welcome. When I teach at Georgia, I have 20 people in the room with me, and 120 on the different campuses that are on the screen. So I'm used to doing this. It's no big deal. Feel free to interact, give some input. Here's why you don't see Saxenda. It's once a day, right? So all these other newer agents are once a week. So once those came out, you know, even in the diabetes world, there was Trulicity, right? It was the drug that was used a lot because it was once weekly. So this is titrated weekly by 0.6 up to a target dose of 3 milligrams once a day. So earlier you had said scarcity. So that's the issue, is we know it takes a while to get to those higher doses, and those higher doses are like gold at pharmacies. It's like if you can actually find it, because that's what everybody's after, because the gold is the higher the dose, the more the weight loss. Okay. So 11 trials have randomized. This is a very well-studied drug. Everybody was required to have the standard 30 minutes, 5 days a week of exercise with the 500 calorie reduction in calories. And what's cool, though, is I love these studies because several of them had a run-in period. This is what I talked about. They had a run-in period, and the weight loss was somewhere between 7 and 13 kilos before they even entered the study. That's impressive, right? You lose 10 kilograms, 22 pounds. That's really good. So that, again, proved to them that they would be compliant or adherent with the drug. And a lot of tirzepatide studies that we're going to go through, that's what they're looking at, is people that have already had weight loss. Can you get additional weight loss with the drug? All right. So in these studies, 4,000 patients, mean weight, look at it. Told you. It holds, man. Like every study is beautiful, okay? Most studies, however, did not have diabetes patients. And of course, we're going to talk about why that's super important for the GLP-1 agonists. So again, very good results, average of 5 kilograms, not nearly as much as we're going to see with the Mounjaro and some of our other agents. They were more likely to achieve, again, 5%, 10%, and 15% of their total body weight loss. By the way, the tighter a confidence interval, meaning narrower, so 1.8 to 2.4, that's pretty narrow. Like if you pull a massive statin trial with like 20,000 patients, it might be like 1.8 to 1.92. Like it's super tight. So that tells you got a huge sample size. You've got a very robust result, okay? So 11 trials, though, that's a pretty tight confidence interval. So you were twice as likely to lose 5% of your body weight with this drug. You were nearly 2.5 times to lose 10%, 3 times to lose 15%. No real, serious adverse effects. But again, the GI side effects, look at this. 40% of people had nausea. So you can go ahead and tell patients, at least half of patients get some form of nausea. People tend to get better, though, with time. And that's the thing. Start low, go slow, titrate. Acute pancreatitis and gallstones have been a concern with GLP-1s, but in these studies, at least, they were pretty rare. Vomiting, too, though, 16% versus 4%. So you're 4 times as likely to have a vomiting episode on these agents. And so that's why, we got to tell patients, you got to titrate slowly. We're trying to limit these. So good drug, but again, once a day, every day, it is sub-Q. In the era of what I'm about to talk about, I don't know that people are going to be using these as much anymore. Now, the insurance companies may surprise us and say, we're going to cover this one, which is weird, but they might. All right, now let's get into some of these that are, all over your Netflix commercials, okay? That's what I tell my students, like when they're studying for their board exams, I'm like, just watch Netflix. And they're like, what? And I'm like, watch the commercials, right? Because the commercials tell you all the side effects, warnings, and precautions. I was watching TV with my son the other day. He's like, Dad, why would anybody take this drug? Right? He's like, why would anybody take this drug? All they've talked about is side effects for the last minute and a half. I'm like, yeah, they're required to do so. We have to be fair and balanced. So Wegovy or Wegovy, I don't know how you say it. I've heard it 2 different ways. So this was FDA approved 2 years ago, 2.5. And it's a 2.4 milligram sub-Q, but look, game changer. Weekly. That's a big deal, right? You can give a dose once a week, but you don't start at 2.4. If you do, people are going to hate you, okay? They're going to be, that nausea and vomiting goes to 100% pretty much, okay? So you want to start at 0.25 for a month, then 0.5 for another month, and then 1 milligram for a month, and then 1.7 for another month. So you don't get to that full 2.4 for 4 months, right? So that's an important point for patients because they're anxious. They want to lose weight quickly, but it's the discussion with them. You know, I have seen some, and insurance companies especially, they've got to see that titration before they're actually going to think about covering it. So 6.2% average weight loss in diabetes patients, 12.4% in non-diabetes patients. So this is a key statistic that's going to hold through all these studies. Much easier to lose more weight if you do not have diabetes, okay? Now, if you have diabetes, do you lose weight? Yes, on the drug. Do you lose as much? No, you don't. You don't. A lot of things fighting with diabetes, inflammatory cascade. There's just a number of factors there. Wegovy, though, is not approved for diabetes. So this is where it gets tricky. Some drugs are approved for diabetes. Some drugs are approved for weight loss. And it depends. So Ozempic, Ozempic, you know, that's for you, Andy. You're going to fly back to Buffalo and be thinking about Ozempic. All right. So good commercial, right? It sticks in your head. Now my evals are going to be bad because, yeah. So Ozempic, right, is sub-Q for diabetes, and Rybelsus is PO for diabetes, right? So, but in reality, the one that's specifically for weight loss is going to be the Wegovy. So semaglutide is an interesting drug because it's got 3 different brand names, right? So that's confusing. And 2 different dosage forms, sub-Q and a PO, right? So a couple of these studies just to show you, overview of the semaglutide studies, BMIs, again, mean weight. What's the middle number between 87 and 113? 100. That's right. Holds every time. Isn't that cool? Come on, I need some credit for that. All right, so again, hypocaloric diet. So again, for Wegovy, here's the weight loss. So in general, about 10.8 kilos. This is one of the higher numbers you've seen so far as actual weight loss. And you can see that for 5% total body weight loss, you're 3 times as likely with Wegovy to lose that than you are with placebo. You're nearly 5.5 times more likely to lose 10% of your body weight and nearly 8 times as likely. But look at that confidence interval a little bit wider, okay? Not as many patients in this group. That's what that tells you. But yeah, it's an amazing finding. Safety-wise, not surprising. GI, a little bit of gallstones, you know, there, and that's something that's being monitored. A friend of mine actually started Wegovy and got a gallstone. So it does happen. She's like, man, I'm too fat. I just want to lose weight. Now I got gallstones. I'm like, yeah, that's why they have the commercials, right? So you may get gallstones. So yeah, so these are the side effects, but overall tolerated. Now, when you compare semaglutide, the Step 8 study compared semaglutide, Wegovy, versus what I just talked about, right? Liraglutide, right? And what did they find? Semaglutide actually crushed it. A lot better tolerated, lot better weight loss. And it was interesting, right? So the discontinuation rate was a lot less in the semaglutide arm versus the liraglutide arm. So pretty interesting because once a week, maybe you're not hitting your GI tract every day with an injection. And so I think that's why the once weekly, another benefit of that. Now, this is what we really want. Weight loss is an intermediary outcome. Because if I cause 15 kilograms of weight loss, but you have more chance of a heart attack, how's that drug going to do? And they're not going to use it, right? Or they have more strokes or more cancer. So that's why we have to have long-term outcomes in these patients. So finally, this was published, and look at this, not even a month ago, it finally came out. Charlene was like, where are your slides, Chris? And I was like, they're coming. I've got to get this update going. Okay. And sure enough, the Linkoff study came out. So this was a multi-center, double-blind, randomized placebo-controlled trial that looked at cardiovascular outcomes. That's what we want. What does this drug do for stroke, MI, etc.? That's what I want to know. 2.4 milligrams weekly, again, after titration. Look at this, so RAR, 17,600 patients. That's what I'm talking about, right? 45 years old or more with a BMI greater than 27. However, important caveat, when you see this all in the news, they don't ever say this, there was no diabetes in this study. So that's a big caveat, right? Because that's a huge population we're leaving out. They're doing its own study on diabetes, but it's not in this initial finding. Primarily white, primarily male. This is a problem with all these studies. Need diverse population representation. Mean follow-up, 3 years. Decrease in major adverse cardiovascular events. Okay, so did it show a benefit? So let's look. Confidence interval. Is that significant or not? Does it contain 1? It does not. So it is significant. Now you say in these other trials, the numbers were higher, right? They were like 3 point this, 2 point, because the outcome was different. The outcome was chances you would lose 10% of your weight. So you want it to be higher. You want it to be 2, 3, 4. This, you want it to be lower, less than 1, because you don't want to have a heart attack or a stroke. So that's why in the news, you will see, it will say, Wegovy decreased your risk of a cardiovascular event by 20%. Where do they get the 20% from? 0.8. What's 1 minus 0.8? 0.2 times 100, 20%. Right? 6.5% versus 8. So this was the first study among the obesity meds to show a decrease in cardiovascular endpoints. Big deal. Okay. That's why if you have Novo Nordisk stock, congratulations. Okay. You're probably doing great. All right. I don't. So we're great. I do have NVIDIA though. So I'm very happy. Y'all know what NVIDIA is? If you don't, amazing. All right. It's a computer chip. Anyway, that's not part of your CE. All right. So look what wasn't different though. Non-fatal stroke. It was interesting when this data came out, all the mechanical device companies that are to prevent stroke, their stock went up like 30% because they had a concern, right? Because that's the big concern, right? As great as this data is, who's quaking in their boots on this data? People who make food, snack manufacturers, food manufacturers, right? And so actually its stock went up because this apparently, at least in this population, did not affect stroke. I would not suspect that in the diabetes population it's going to affect it either, but we don't know. We got to wait and see. Look at this though. New onset diabetes. Remember I talked about 500 million people by 2030? It cut the diabetes incidence, again, because this drug's used for diabetes, right? But it also is, the thought process is GLP-1s earlier in the game can prevent diabetes. So I actually think this is where the biggest weight benefit is going to be, is preventing diabetes, pushing it down the road. If somebody can have diabetes for 10 years instead of 20, that's huge. That's a huge on the healthcare system from a cost standpoint. So that's going to be looked at more. Let's see here. Andy, as far as admitting that person. So discontinuation rate though, 16 versus 8%, GI side effects. Shocking, right? That's what we've been talking about. So this is the pre-diabetes stuff I was talking about. So this was a 68-week study that looked at, okay, what's the incidence of people acquiring diabetes if they're on semaglutide versus not? Step 1 trial, step 3, step 4. I have no idea what happened to step 2. Just so you know, I'm always a little weirded out by that. Like, where'd that trial go? But you can see that the normoglycemia, there's a bird in here. That's interesting. I'm putting the laser on it just to see what it'll do. Not their eyes. Not their eyes. Okay. Little birdie. Yeah, seriously, there's a bird right there. Normal glycemia. That's the first time I'm speaking for 25 years. Never had a bird come in the room. So, but anyway, normal glycemia, nearly 90% of patients on semaglutide, only about half on placebo. So you can see nearly a 30 to 40% change in preventing diabetes. So I think that's where we're going. I really do. I think that's where we're going. Instead of waiting for things to happen, i.e. diabetes, the next step is let's prevent it from happening. Ounce of prevention is worth a pound of cure, right? Who said that? I think Ben Franklin. I don't know. Maybe he did. So semaglutide from the studies may be prioritized over other agents. GI side effects not uncommon, but we do want to titrate. Again, GLP, GI. That's what you want to think about. Increased potential for adherence over liraglutide. That's once a day. Now, though, big deal. We got cardiovascular outcome trial that shows positive outcomes. So I think this is going to be one of the first ones that gets some insurance approval. Obviously, there'll be criteria such as have they tried this weight loss, et cetera, et cetera. But I think that's where we're going. If the oral version, Rybelsus, if that ever shows the same thing, that is a massive game changer. I think then you've got a drug that's oral that people will take every day. Could be huge. Although I'll be honest with you, the sub-Q weekly, I think a lot of that has changed in the last 10 years. People fear needles. The other thing about the device is it's pretty easy to give. So once a week, people can typically deal with that. When they think needles, they think insulin 2-3 times a day. That's not what they're after. So this is the oral drug. This was published in June in Lancet. In the Oasis 1 study, again, this is early, but 9 out of 10 people achieved 5% weight loss for the oral version. And this was very comparable to the subcutaneous version. And the GI side effects were overall mild to moderate. So they are pushing towards this because if you can get an oral GLP-1 that decreases the risk of a heart attack or death, that's $1 billion drug. I mean, let's just be real. Okay. So guideline summary, semaglutide gets the highest marks. These others are kind of low or moderate. Now let's talk about coming attractions. Now, these are things you probably haven't heard of a whole lot. I'm going to close out. Don't worry, I'm getting to Mounjaro. Okay, I'm getting there. All right, I'm keeping you on the edge of your seat right here in Vegas. All right, you're waiting for the slots to come down to see what's going to happen. All right, so danuglipron. So this is an oral drug as well. This is early. This was published earlier this year. So this is a small molecule GLP-1 agonist. So the smaller the molecule, maybe less GI side effects. And this was a dose finding study. But again, not a problem, but look how it's dosed. It's PO. That's great, right? Twice a day. That's going to be hard to compete when you got once weekly injections. You better lose a lot of weight on this. And unfortunately, in here, they didn't lose a ton of weight compared to placebo. So you're talking about, 2 kilograms or 4 kilograms relative to placebo. A few of them lost 5% or more. But again, you say, man, why didn't they lose a lot of weight? Well, the biggest thing is this study was only for 16 weeks. So you really can't make a good comparison, apples to oranges, compared to the GLP-1 agonists, the other ones, because it was a short trial. So more studies are coming. It's too early to make a call, but the oral is nice, but it is BID. So I don't know how that's going to play long term. We're going to be more wait and see, but the name of that drug is danuglipron. I think it's a Pfizer drug, if I remember right. I could be wrong there. Now, retatrutide. Okay, now this one's interesting because it's 3 mechanisms of action. So you've got the common GLP-1 that you know and love, okay? You've got the GIP, which the two of those together essentially are tirzepatide, which we're going to talk about, but then it adds glucagon. So it's actually 3 distinct mechanisms of action. So this was a phase 2 trial over 48 weeks, and it did show a 20% difference in weight loss at the highest doses. Something to keep an eye on with this drug. So this was published in New England as phase 2, not phase 3, with complete weight loss and outcomes. It did show some dose-dependent increases in heart rate. Now, what does that mean? I don't know yet. If it's, I'm 47 years old, I don't have any cardiovascular disease, maybe not that big of a deal. But if it's a 65-year-old diabetes patient with AFib, that could be a problem. So I think working that out, seeing what's going to happen with that will be key long-term. All right, so before we go into some of these other agents, I want to give you a patient case. So read through that. I'm going to take a quick sip of water here. Okay. So KM's a 37-year-old female. She's a teacher. She has diabetes. She has prescription benefits. She's been on semaglutide 1 milligram once weekly for the last 6 months. Okay. She's also on maximum tolerated dose of metformin. Her BMI has dropped. She's gone from 35 to 31. And her A1C has also gone from 8.5 to 7.2. Despite her progress, she's frustrated that she recently has plateaued, continuing her weight loss goal because she really wants to get close to normal. She recently saw a commercial for tirzepatide and says, hey, what about Mounjaro? What about it? Right? Y'all getting this question? A lot, right? So she's on 1 milligram of semaglutide. So let's talk about kind of how we walk through this. So Mounjaro, for my Teach Me Farm website, I recorded a video and I called it, What's the Skinny on Mounjaro? Because I was getting so many questions. Y'all get that? All right. So a lot of questions on this, right? So this is a GLP and a GIP. It's approved for diabetes, but now there's a different product approved for weight loss that we will talk about. It's the same drug, just a different brand name, okay? Reduced A1C, more than Ozempic, more than Lantus, which is pretty impressive because Lantus is insulin, right? And more than Tresiba. The dose is pretty low at 2.5 once a week, titrate to 15 milligrams once a week. So barrier contraceptive for 4 weeks after initiation. The concern is with this drug, there's some old data showing that it may push oral contraceptives through the GI tract faster because of its mechanism of action, and then they wouldn't get absorbed as much and they would be less effective. The clinical outcome data with that is very, very not seen. But at the same time, you still need to counsel our patients on it. So with that, the question is, titration-wise, it's weekly. So it's a quicker titration than what we saw with Wegovy. The key is finding the drug and finding the dose. So one of my staff at the Savannah campus, she's lost, I think, about 65 pounds on Mounjaro. Now, she had trouble, though, finding the higher doses in Savannah. Like, she was going from pharmacy to pharmacy, trying to find it. But she still lost a lot of her weight on the 7.5. So it's not like if you get to 7.5 and that's all you can titrate to before nausea and vomiting kind of becomes too much. You can still lose a decent amount of weight on that. So let's talk a little bit about the data. So weight loss, there's a lot of these SURMOUNT studies, okay? Everything's a mount with them. Mounjaro, SURMOUNT, okay? It's a mountain, all right? So SURMOUNT 1, no diabetes, but look at the weight loss. 15%. We haven't talked anything like 15% yet. We've been talking a lot of 5, maybe 10. A few people lost 15%, but 15% was the low number here. 19.5. Or if you got up to the 15 milligram dose, you're losing 21% of your body weight. Now, let's see how many of you have been listening. What is the average weight of patients in these studies? 100 kilograms. So if you're losing 21%, how many kilograms are you losing about? About 21. So you're losing like 40 pounds. So that keeps it in perspective, right? So anytime you look at these studies, keep in mind that 100 kilogram, because then you can take any of these and get a pretty good idea of how much they're losing. See? Now, Surmount 2, the sequel. Sequel's almost never better, is it? It's always worse, just about. Okay. All right. So, but I will say I'm a huge Hunger Games fan. I went and saw the prequel. It was actually really good. It's really good. All right. So Surmount 2, the diabetes trial. Okay. So they included diabetes, and you can see that they did lose about 15 kilograms, either in the 10 or 15 milligram doses. And these were followed for like over a year. That's impressive, okay? So even in the diabetes patients, they still were losing about 15% of their body weight. So not quite the 20% that we saw, right, with the non-diabetes patients, but they did lose about 15%. That's pretty good. So they're talking about 30 pounds, okay? Diabetes patients losing 30 pounds, when do you see that? Never, right? So approximately 8 out of 10 patients received at least 5% weight reduction. That was only 3 out of 10 for placebo. Now, Surmount 3 and 4, this is essentially what led to the FDA finally giving them the weight loss indication, okay? So Surmount 3 was a 72-week study for people who had already lost 5% of their body weight during the lead-in. So essentially what they were trying to do is say, okay, we're going to take patients that during the lead-in period, when it was just exercise and calorie reduction, they still lost a lot of weight. Now we're going to put them on a drug to see if they still lose weight, meaning that, is it really the drug? Does the drug have a benefit even if they lose a lot of weight in the beginning? And the answer was, yeah, look at that. They lost an additional nearly 20%. And look at placebo. They actually gained 2.5%. Not surprising, right? Look how long the study is. 72 weeks. What I didn't tell you on the beginning, I lost 70 pounds, right? But I've gained about 20 of it back over about 20 years. Okay, about a pound a year. All right, not terrible, but not where I want to be. Okay, it gets hard, man. That metabolism shuts down, don't it? You turn 40, man, that check engine light comes on a lot. I'm just telling you, it's a lot more than usual. So side effects leading to discontinuation, a lot higher GI. That's the issue. I will say though, the GI tolerability seems to be better with the GIP GLP drugs than just the plain GLP drugs like Ozempic or Wegovy. Okay. Now, Surmount 4, this is not yet published. I could only find it essentially in online, just like a press release. So this was kind of an interesting study. It was a year-long study of tirzepatide after a 36-week open label lead-in. And what's funny is in that open label lead-in, patients lost about 21% of their weight. By 88 weeks, they lost another 6.7% of their weight. Look at placebo, man. 15% back. They gained 15% back. So again, drugs are great, but you got to be on them. You can't stop them. And, and that's the big concern, right? Patients can't afford it. Although I will say, this is an interesting drug class. From a pharmacist standpoint, people mortgage their kids, I think, to pay for this stuff. It's really interesting. Like if a Atenolol goes up by $1, they're like, I'm not taking that. Right? Or their statin goes up 50 cents. They're like, nope, I'm done with this thing. Mounjaro goes up $100. No big deal. I'll just buy it. I'll mortgage my pet. All right. So it's true, right? People are very aggressive with this. So November 8th, 2023, I'll never forget. I was in the airport actually, and I was on my phone. No, I was in a hotel. And I was reading, I was preparing, and I was getting ready to do some of Charlene's slides that y'all are seeing today. And then this came out and I was like, well, time to redo my slides. Okay. And so Zepbound. Now, how many of you have actually seen Zepbound in your pharmacy? Supposedly it's available. Okay, I haven't seen it either, all right? But the company says it is available now for ordering, okay? So it was approved on November 8th, but here's the actual FDA approval, just so you know. Adjunct, that's key, to reduced calorie diet. What have you seen in the studies? How much did they tell people to reduce their diet? 500. You guys are paying attention, okay? So about 500 calories and increased physical activity for chronic weight management in adults. This is only for adults right now in the standard BMI categories that you have seen in every study we've talked about, except for the Xenical study that went down to 25, okay? Similar to Mounjaro. It's basically Mounjaro, y'all. It's just a different name, right? Because Mounjaro is for diabetes. Zepbound, no idea why they call it that. Does anybody know? Why do they name drugs terribly, right? You ever thought about that? I mean, it's just terrible. Years ago, there was a statin called Cerevastatin. Y'all remember this one? It was called Baycol. Bayer made it, and it was for cholesterol. That makes sense. A lot of these brand names, I don't know where in the world they get their naming rights. Y'all ever get surveyed for brand names? I have. I've been surveyed asking about brand names. And I'm like, I didn't think it was this hard, but okay. Zepbound. I'm sure there's something in there. Okay. So same thing, stop in pregnancy, 2.5 milligrams, sub-Q in the abdomen, thigh or arm, rotate sites. Now, let's talk about our patients. So, oh, by the way, so there was a study or an article in Wall Street Journal this week that said, because people were asking, okay, what if people, because insurance companies, that's the big question, right? Are they going to cover these or not? So Eli Lilly, the company that makes Zepbound and Mounjaro, has said that if somebody's insurance will not cover it, they will charge them a cash price of $550 per month. Now, what's interesting is Mounjaro, people have been paying $1,000 a month plus for that for a while. So I think they're very smart here. That's going to ensure that all those people that were on that are probably going to go to this. And they'll be like, man, we're getting it for half of what we were. So we'll see if that comes to fruition. But that is what was in the Wall Street Journal. We know everything you read is true, right? In the news. So, but in all seriousness, hopefully that is the case. So for our patient, a lot of questions. Number one, semaglutide 1 is not the dose that is in the weight loss trials. It's 2.4. So this is essentially like an Ozempic version. So you're not really comparing one thing or another. Is it reasonable to switch? Sure. If the insurance will cover it. So in my institution, I have an ambulatory care expert, and she has told me via text right now that there are some commercial plans that are covering this now, but it's not many. And so depending on the insurance, that's really what's going to dictate this, or they're going to have to pay a cash price. And these copay programs that used to be out a lot. So my staff member that lost all the weight on Mounjaro, she was one of the last people to get the $25 coupon to where all she paid was $25. Okay. Those are almost non-existent now. Have y'all seen those around? There are a few of them around. So what will insurance companies do now? I don't know. So that's going to be the question going forward. I do have a final case here before we move on to test your other drug knowledge. We'll see how awake you were. So DL is a 50-year-old male, past medical history of obesity, seizure disorder, and stroke, which occurred 5 years ago. All of his lab values are within normal limits. He reports one episode of pancreatitis that occurred when he was 30 after attending a bachelor party. He has not consumed alcohol or tobacco in over a decade. No other GI issues. His work schedule does fluctuate a lot day to day. So that is something to keep in mind with this. Despite this, right, he is making some lifestyle changes and is looking for aid for his weight loss goals. So which one is going to be the most appropriate? So we got phentermine, topiramate. We got naltrexone, bupropion. We got liraglutide, and we've got semaglutide. Now, for the sake of time, I'm just going to skip through. You can get in your head kind of, what you think the answer is. So because of his seizure history, which one of these are you a little bit leery about giving him? Bupropion, exactly. So bupropion, Wellbutrin in higher doses is definitely associated with lowering the seizure threshold. So that's probably not going to be ideal. He has this kind of distant, pancreatitis. I don't know. He's 30, probably was drinking a lot of the time. Okay, but nothing since. So I don't consider that the same as somebody who's just constantly drinking, alcoholism, pancreatitis chronically. So the other thing too is he does have this cardiac history. He had a CVA, right? So we know with the drugs like phentermine, they are linked to stroke. And so that's probably not going to be your best drug. So in reality, it's probably going to be one of the GLP-1s. What does his insurance cover? Once a week would be ideal for him because of his schedule that's all over the place. But again, insurance will probably dictate that. So what are the gaps that are left? I got to see some more long-term outcomes. Does tirzepatide, Mounjaro, now Zepbound, does it decrease your risk of heart attack or cardiovascular death? That's the question. If it does, it's a billion-dollar drug. If it doesn't, it's not going to be. It will crash. You will see stock drop like 30%. Okay. Cancer risk. I worry about it, right? Because it's not until you get thousands upon thousands of patients on a drug for months and years that you figure out some of this stuff, right? Remember, statins were on the market for 10 years before we realized that they can actually cause new onset diabetes. Now, some of that's because they're living long enough to get diabetes, okay? But comparative efficacy versus other meds or bariatric surgery. I'm writing an article right now for CE for a company, WebMD, and it's going to discuss drugs versus bariatric surgery. I'm almost doing it as a debate, right? Because the bariatric surgery has all the outcome data. We got so much outcome data that it decreases mortality, but it's permanent. And all of us have seen a bariatric surgery that didn't go well. Malnourished, psychiatric issues. There are a number of different things that can occur, but there are a lot of successful stories post-bariatric surgery. So more disparate populations. We need more African-American patients in our trials, need more men, need more Latino patients. So some of these are pretty homogeneous in their population, and we need more. So conclusions, more data to come. GLP-1s are going to be where we start for most of them. Look at tirzepatide long-term, be looking for outcome data, hopefully in the next year or so. And the oral therapies will be interesting to see if they can show the same benefit. So it's about 9:30 real quick. Any questions? Yes.
Bariatric patients, post-bariatric, they put their weight back on